brought this USB vintage stick. This is also a proof that we were here 11 years ago. And I brought my presentation on this one, so thank you for that gift many years ago. And where are you, Ruth? Thank you for organizing this together with Carl, and thank you for arranging the conference. I would really like to thank the scientific committee for all the work they have done. As Thomas said, I'm a GP by training. I still see patients. I'm also a professor in general practice in Norway. And recently I got a new position at our university hospital in Copenhagen, where I do work on too much medicine. And my presentation is based on this Danish textbook called Soon We Will All Be Patients in Danish. So I have a conflict of interest because when you write a textbook in my country, when it sells more than 750 books, then you will get some royalty. But my presentation is also based on a soon coming textbook because Alexandra and I have a contract now with Oxford University Press. And when I left it last month, the book, it was all in English. So we need some few rewritings and then a deadline New Year's evening, and then you will hopefully be able to read it, those of you who do not read Danish, next year sometime. I want to clarify what I'm talking about because I've been in this business for so many years and I hear so many terms it could be quite confusing going to this conference if you are new. But for me, what we are talking about is the overarching theme is too much medicine. And in this, you could also say over-medicalizing. And in this, you have overuse as another subsample of that. And then you have these merging concepts of overtesting, overdiagnosis, and overtreatment. And in 2018, we tried, before we had the conference in Copenhagen, to go out and define what we meant by overdiagnosis. Because I have to tell you, there is not an agreement in the international literature about how to define it. But I and colleagues wrote broadly, overdiagnosis means making people patients unnecessarily by identifying problems that were never going to cause harm or by medicalizing ordinary life experiences through expanded definitions of diseases. I have done a shorter version in the English coming book, so there I just say, overdiagnosis means making people patients unnecessarily, full stop. And then you can look at overdiagnosis as an action, and for me, we can do it in three ways. We can find too much, we can define too much, or we can invent a new diagnosis. So over-detection, over-definition, and disease-mongering. I did a talk for some GPs, European GPs, that are doing research, and then they asked me, how do you do research in this? And then I tried to operationalize it, and what I see is, could you pour some water to me? Is that what we are doing as researchers is we are looking at deviations, abnormalities, risk factors, and pathology. I also want to emphasize what I mean by evidence-based medicine because I don't think about evidence-based medicine as algorithm medicine. I lean towards the McMaster people, Gordon Guyatt and colleagues, where you include all three areas. So this is about best available evidence, this is about the clinical context, and this is about patients' preferences and values. And Carl set the scene quite nice just 5 minutes ago because he says this is going the wrong way. And this was illustrated beautifully by some of our Australian colleagues with Alexandra Barrett in the front, where she put up this beautiful figure that I've actually translated it into Danish. also, because it shows what is going on in our healthcare systems. They say there are 3 numbers we have to know, 60, 30, 10. And this comes from Australian empirical data, English data, and American data, and it's mostly from hospitals. That 60% of what is being done in healthcare is okay, it's evidence-based. 30% is low-value care, it's waste of resources, and 10% is harmful care. And this conference, for me, is about the red zone, the 10%. They also put it in a sustainability context and talk about the carbon emission, but go and read the paper if you're interested in that. I'm not going into details about that. I really like what Carl said 5 minutes ago. What should we do the next 10 years? And I want to try and set up a scene and say, what should we do to mitigate, prevent, avoid, diminish overdiagnosis? Because until now, we have mostly described overdiagnosis. This is a very important paper for me. We have tried to publish a similar paper in Denmark, but journals don't like these kinds of papers, where you actually try and quantify how much overdiagnosis we have in our societies. This is Australia, this is Paul Glasgow and colleagues, and this is women, and it's all women in Australia with a cancer diagnosis, and nearly 1 in 5 are overdiagnosed. And you can see it's 4 cancers that are driving it. It's throat cancer, renal cancer, melanoma, and breast cancer. Now I will switch to the next slide. That's men, and here you can see it's even worse for men, and that's because prostate cancer is more overdiagnosed than breast cancer. And I know Michael Borg, my colleague from Denmark, will talk a lot about that in his keynote. So just look at the breast cancer bar now, and here you see the prostate cancer, and you can see it's worse. So now we are up to nearly 1 in 4 men. If we look at the cardiovascular area, it's even worse. This is Norwegian data. This is Halvdan Petersson's PhD. He applied the cardiologist guidelines from 2007 on a population in Norway. And those of you who do not know Norwegians, they are getting really, really old, these people. They're super healthy people. But when you apply this guideline on this population, less than 4% are healthy. And the guideline has just been changed in 2024, last year. And what do you think happened? They lowered the thresholds even more. So I don't think there are any green zone left, so maybe the 4% are gone. So now there's no healthy people in Norway. There's a certain inequity in this. Fisher and Welsh did this beautiful, simple study where they looked at high-income and low-income areas for 4 cancers and then said, what is the mortality? The mortality of those cancers are the same. What is the prevalence, the incidence? It's higher in the high-income areas. Why? Probably because of health insurance, private health insurance, more screening, more visits. We have also done a lot of qualitative studies. Kirsten McCaffrey has done studies. We have done studies where we're trying to talk to those people that probably are overdiagnosed. And it shows that it's super harmful. It affects people. It contaminates their everyday life. And this is people, men with abdominal aortic aneurysms. This is men with prostate cancer. So what I see when I read the literature, and I have done this textbook and published it in 2022 and now updated it into English, is that if we as researchers should go forward and listen to Carl, then we need to look at the causes, incentives, mechanisms, and drivers. Otherwise, we can't do anything about it. It's not enough just to describe it. Our Norwegian philosopher colleague, Bjørn Hoffmann, published the first paper on this area. And he's a philosopher, so he was of course, doing a lot of thinking. He had read the literature, and he made this map of what drivers are there to overdiagnosis. And I agree with all the drivers after doing the textbook. And 3 Australian colleagues did this literature study and mapped the drivers to overdiagnosis. This is all the ones on the left side. The problem about doing a scoping review or a literature review in this area is that if you only look in the medical databases, you will not see a lot about causes, incentive, drivers, and mechanisms. And the social scientists have just started their research in this area. So this is the limitation here. On the right side, they did a lot of suggestions for interventions. They are all hypothetical. They are not based on evidence. And after we did the Danish book, we had 7 chapters, and then we realized that we needed an 8th chapter to try and tell our colleagues what is needed in the research area. What do we not know? So this is our mapping that is very similar to the 2 previous ones. However, we are trying to approach it also from a clinical point of view. So we talk about a macro level and a micro level on health culture. And by health culture, we are using social scientist theories. I can recommend you to go to Ville Pearson's session tomorrow. Although I'm doing a parallel session, of course you should come and listen to me and not Ville. Or you can go to a later session tomorrow afternoon where social scientists will talk about the epistemology in overdiagnosis. And I think we can learn a lot from the social scientists because we have these tendencies in our culture where health becomes a super value. That's healthyism. Carl said it, we have a health culture where we think more and earlier is better. We also have a health culture where we think we are responsible for our own health and we should do, as citizens, something about it. And we meet that as GPs a lot. They come with all these questions because they feel like they are responsible citizens. And then Bauman describes this beautiful paradox where we all the time are looking for the meaning of life. However, the mortality is 100%. So how do you handle that paradox? And when I teach students, I normally say, do you know that the mortality in this room is 100%? And then they do like you, they start laughing. Christine Damhus, who is also attending this conference, and I and 2 other colleagues wrote this paper where we are trying to go into a discussion of one of the logics, early diagnosis, and using some of those theories. And actually also using epidemiological evidence showing that there's no proof or good evidence around early diagnosis being so beneficial. I can't go through all the drivers we have looked at. If I should look at it, then I put up the political actors, public actors, and I have talked to the people in our governmental health insurance and where you can claim for mistakes, and we don't have any cases where people have complained about too much. Too late, too little, that's the complaints, not about too much. And when we look about the scientific actors, I really like this case of hypertension that has been lowered since I started studying medicine in the 80s. And the American Society lowered the threshold for hypertension from 140/90 to 130/80 with this paper. And then Jenny Dost and my Norwegian colleague, Per Vanvik and colleagues, wrote this paper about how could you How could you make a checklist and go through a disease definition when it's changing? And then Katie Bell and colleagues used this checklist and proved that it did not have a benefit that outweighed the harms when you lower the threshold so much. But nothing has changed. It's still out there. And I mentioned the European guidelines are following the American guidelines now. And 2 days ago, Andy Solomon and I got this paper published, accepted for publication, because now the definition of sclerosis is changing. So now the definition of this diagnosis is no more just patients with symptoms. You can get this diagnosis being asymptomatic. So there's a risk of overdiagnosis. I think the paper will be out in a couple of months, but we got it accepted 2 days ago. So my question is, who has the right to define a diagnosis? Who has the power to say, we know the truth? Is it really organ specialists that should define it? Several years ago, Ray Moynihan and I and other colleagues tried to raise that debate. It never raised, but we tried to make a paper about redefining disease definitions. And if you look at interest organizations and political actors, we have patient organizations all over the world pleading for melanoma screening. We also have physicians doing it, and there's absolutely no robust evidence supporting that. So as a clinician also, I want to emphasize that if we only try to intervene on this clinical room, we will never succeed in diminishing overdiagnosis. And Viola's session is about who has the responsibility. So of course you should come to mine, but then you can check out her session as well. So my problem is that if we are looking at diminishing, preventing overdiagnosis, we have to go out to look at the macro level, and we as medical doctors are not trained to this kind of research, so we should start collaborating with people that are trained to do this. Social science is my guess we should try and talk to. Because we see how the health culture is affecting both citizens, patients, and health professionals. This is what hacking calls the looping effect. And here you have Tammy Hoffman and Kristen Ma's beautiful 2 systematic reviews, where they can see that people are overestimating the benefits of screening and underestimating the harms. So we as doctors are also living in the health culture. We are also affected by it, and we are also creating it. And we are also the problem. One of the best papers I've done with Christina happened by accident. We gave people an information leaflet that was evidence-based in cervical cancer screening. And they produced it, they produced the words. And they understood everything that was in the folder. However, when we put it all together, all the benefits, all the harms, what happened was cognitive dissonance. They couldn't perceive the information anymore because it was against their own beliefs, their own health culture. They thought that earlier is better and more is better. And we call that a perception gap. And that's exactly what is happening in the clinical room, that we as physicians can be really good at talking to our patients. The problem is we are talking towards a wall of health culture and attitudes and thinkings and theory and so on. So my summary for future research would be, for the next 10 years, we should identify incentive causes, mechanisms, and drivers. And please look at it, it's at the macro level. Then together with all the stakeholders, we should try and develop interventions that is targeting those drivers. And then we should run proper intervention studies on these areas. So that was the last word from me.